Hello everyone, good evening. So today I have the opportunity and pleasure to start the program after giving the introduction to our Dayaya. So we call him Dayaya all the time. So this is the second episode of online Meet Your Expert session. So the plan is to make a kind of tutorial for the further referral in future, as well as to that's the main aim. The other aim is to to interact with the expert in one subject and get your queries clarified. And so that's kind of thing. So today, our guest speaker is one of the eminent and renowned eye surgeon in Sri Lanka. He is one of the rare breed who can operate in anterior and posterior segment equally and fluently. So he's a great teacher, mentor, and a very great colleague. So I learned first VR step from him. So when I was entered in this pathway in 2008. So though his name denotes for war, he's a quite peace-loving character. So he's none other than Dr. Ramasiri Dayawansa, consultant eye surgeon, National Hospital, Colombo. So he's going to talk about our bread and butter, the basics of um, the cataracts, the measurements of the cataracts. So I would like to invite him to start the session.
So can you hear all?
Yes, we can hear.
Okay, video can paint it's okay, ne? You can hear, ne? You can see the slides? You can see the slides?
We can see the slides. Yeah, yeah.
Okay. Okay, you can see the my presentation, ne? Okay.
Yeah, okay. You can see.
Right, good evening, and thank you very much, Dr. Mangala, for your kind introduction. And today, actually, it's an honor and privilege to talk to you, all of you, regarding the basic interpretation of the biometry. So biometry is actually basically one of the basic tools. It must be interpreted properly to get your correct outcomes. Nowadays, cataract surgery, which is actually one of the most common eye surgery performed everywhere, and the cataract surgery is considered as vision enhancement surgery. So early days, it was thought like vision restoration surgery. The difference between vision restoration and vision enhancement, Mangala, I can't actually get my video. It's okay. That's okay. So we just go with that. You can hear it. That's okay. Now, early days, actually, we thought of having vision enhancement. So earlier we thought of vision restoration. That means when somebody comes with you with the cataract and the present with the maybe PL or HM vision, so after surgery we can give the vision back, maybe 624, 636, whatever the vision they gain is considered as a vision restoration surgery. But nowadays the concept has been changed. Now it's called vision enhancement surgery. That means not only to give the vision, it should be perfect vision. And the visual acuity, contrast, and all the sort of refinement should be there to enjoy the visual outcome by the patient. For that purpose, the biometry plays a vital role. And that is number one. The number two is, now this is my outline of what I want to talk to you. Now it's like the basic biometry techniques and how you interpret the biometry report. And there are certain special areas to be considered, and few cases of actually in practice biometry. And so here we are actually, what we are talking about now, the importance of biometry. One thing is actually, it is a key to successful phacoemulsification surgery. And now nowadays, the modern biometry is, it gives a invaluable sort of assurance or the support for us to monitoring certain diseases. Say, for example, now people are with the high myopia or maybe astigmatism. So often they come and ask us, so whether the disease progressed or what is going to happen, all sort of questions they ask. So what do? We just look at the refraction report and so try to comment on that. But the present day biometry, which gives a invaluable support to get the eye basic measurements, which is a very good tool to monitor the progress of certain diseases. So that's another the key advantage of having these biometry machines. Now, the basic biometry, what we were familiar was actually the ultrasound biometry. So it is performed using either contact method or the immersion method. So, and it has been changed to the optical biometry. That is basically what we have is IOL Master 500 and IOL Master 700. Now, understanding the ultrasound biometry, what we have is, this is a ultrasound probe. It's nearly about 1 centimeter or maybe 8 to 10 millimeter diameter, the probe, which has to be fixed onto the surface of the eye. So that is what is called contact biometry. So you keep this probe and it touches the center of the cornea, and then this ultrasound waves passes through the cornea, lens and the vitreous and hit on the fovea, and the return will be analyzed. And the person who does the biometry has to be carefully adjust or orient this probe onto the eye. It should be in such a way, should be the perpendicular to the cornea. And if there's any sort of angulation or whatever thing, the ultrasound wave which go and hit on the back of the retina will not be exactly the fovea. So then actually your measurement will be changed. So therefore, whenever you do this biometry, you have to look at the spikes. So these first two are the corneal spikes. This is the one which is the retinal spike. So you have to be very carefully, it should be very perpendicularly oriented spike to get the correct value. And so that is the contact biometry. And to overcome that part, and to actually get the job easily done, people have revolutionized that part with this is called Pragishell. There's a plastic sort of container. So this part is going to fix on the cornea. I mean, it's fixed onto the globe around the cornea, and this is fixed into the ultrasound probe. That is what he's using. Probe is fixed onto the front part, the top part, and the bottom part is fixed onto the globe. And this small area is to fill the chamber with the whatever the saline or whatever the fluid you are going to use. So basically, you can eliminate. Now, this contact part is being actually removed by this one. So the probe is fixed to the Pragishell. The wave is passing through the media and hit on the cornea. So therefore, the person who does the biometry doesn't need to touch this probe onto the cornea. So it's going to deliver the purpose without touching the cornea. So it's a bit of relief thinking of this angulation and all sort of errors. And so that is the immersion technique, but still it used the ultrasound, the waves to get the axial length. And the modern version is the IOL master. So those are the optical biometers. So optical biometry, what they do is actually they use the partial coherence interferometry, and it's non-contact, and the patient has to look at the sort of whatever the light inside the machine. So therefore, there's a much assurance that the light ray will hit onto the fovea. So the axial length measurement will be much more accurate. Now, another problem with this ultrasound probe, so this probe is at nearly about 1 centimeter diameter. So whenever the ultrasound waves pass, it is not exactly positioned onto the fovea. It is positioning around the fovea because it's a bit of about nearly 1 centimeter diameter area. In case if you do ultrasound biometry on the high myope, imagine now he is having a sort of staphyloma. So there's a high chance this probe might catch the retina around the fovea, but not exactly the fovea, because there's a staphyloma. So we might miss the length difference. Therefore, always advisable to use the ultrasound, the optical biometry more in case of especially the myopic patient. So this one, but only the issue with the IOL Master 500, they use the interferometry technology, and there are some issues with the hard cataracts. Now, most of those our cataracts, it cannot be measured using this IOL Master 500 machine. Then therefore, actually in IHospital, we have the IOL Master 500. So whenever we send for the biometry, half of the people, they come out with ultrasound report because it cannot, the light ray cannot pass through this sort of harder cataracts. To overcome that the company has revolutionized the technology to IOL Master 700. It is again a non-contact optical biometry, but it uses the newest technology, that is a swept source OCT technology. So it has the advantage of measuring, it can measure the both anterior and posterior surface of the cornea, both anterior and posterior surface of the lens, and it gives a very accurate K values and a very accurate entry chamber depth values. And it has actually, machine has now if you look at the screen, it shows from cornea up to the fovea. Now, this is as I said, it is a OCT, swept source OCT. Therefore, it gives the macular OCT picture. That is a huge advantage. Even the surgeon misses the macular pathology, the machine has an ability to pick the pathology on the macula. And it happened to me and most of the other people who use the IOL Master 700. Actually, it is not available in the government sector. That the private sector, the few machines are available. So whenever we send for biometry, the technicians comes and say there are certain, the macula is not very clear and something happening. So therefore, we used to take a OCT macula. Then actually we will pick. Maybe we might have missed the ERM. We might have missed the sort of macular hole. So that is a huge advantage. Even you miss it, so machine will detect the macular pathology for you. And this one actually, it does the 2000 A scans per second. The tissue resolution is about 22 microns, and very fast, very accurate scanning using the swept source OCT technology. And it, as I said, it uses the parameters, the posterior cornea, the posterior cornea's the morphology and the total keratometric value. And there's a new thing called Cheng-Wearing code, so the CW code. If you need, you can use this, and that is another name for actually angle kappa. So we'll go into the details in a minute. And it provides full-length OCT image of the eye with fixation check. And as I said, the keratometry, it gives very much accurate keratometry values than the IOL Master 500, because IOL Master 500 only use a single ring, which is 2.3 millimeter diameter. It's a single ring with 2.3 millimeter diameter. But the IOL Master 700, it uses three zones, 1.5, 2.5, and 3.5. There's three rings zones. It will evaluate and ultimately gives us the very accurate keratometry value. And this is the OCT layout we will see in the IOL Master 700. So this is the cornea, this is the iris, and this is the anterior surface of the lens. This is the posterior surface of the lens, and this is the fovea. That is why where I told if there's any sort of problem happening on this area, this will be so picked, and we can re-evaluate the macula before going for the confirmation the biometry report. And this is actually now so cornea. This is actually pseudophakic eye. There's a lens inside, so you can pick whether it's a phakic or pseudophakic by looking at the biometry, the report. And in addition, it gives nowadays biometry formulas. Actually, now we go into the details in a minute. So present biometry, basically with the SRK-T, what we use is actually we use the axial length and the keratometry values only to get the biometric value. But nowadays, the present era, people are thinking about effective lens position, where the IOL is going to sit in the eye. To get that detail, we will need a thing called the diameter from wide to wide. So this is called wide to wide diameter. To get this whether it's accurate or not, actually we can see the image and whether the image is correctly superimposed onto the eye before you get the reading. So this is very useful tool. You can get the basically accurate white to white reading. And these dots actually, this is the thing actually I was talking about the Cheng-Wearing code. These dots, so if it is not correctly aligned with the pupil axis, that's where we get problems in the angle kappa. And the Cheng-Wearing code or the angle kappa, now if you get the report, now this is white to white, this is what we are talking about. If you see the Cheng-Wearing code, it says Cheng-Wearing code is 0.8. So there's a difference between pupillary axis and the visual axis. So this is very, very useful tool whenever we think of giving the patients the premium IOLs. Basically, the multifocal IOLs. So if this is not aligning correctly, I mean, visual axis and the pupillary axis, when those are aligned correctly, there will be some problems. Patient will end up in as unhappy patients. So general recommendation is actually whenever there is the Cheng-Wearing code, the value, if it is more than 0.5, most of the people believe we should avoid using premium IOLs on those patients. So that is an added advantage of having IOL Master 700. This is a Cheng-Wearing code measurement. Then even you look at this picture, you know this is not correctly aligning. So then actually you can see the value. And it gives a white to white value, and this gives the axial length, corneal thickness. If you want, you can take, because it measures the front and the back surface of the cornea. It gives a correct, accurate anterior chamber depth value, and this gives the lens thickness. So it's very, very useful tool. This is a white to white. So these measurements are mandatory for nowadays present IUL formulas. Now look at this change. K1 is 43, K2 is 48. So difference delta K is -5. So remember this part whenever we go for calculation of IUL power. I will come into it very, very in a minute. Now, next see how to interpret a biometry report. Now, say for example, now take this report and you have to check the details, personal details first, the patient's details, date of birth, and so on to correct whether you are checking the right person. And then actually it's a right eye, this is a left eye, and it will say whether it's a phakic or pseudophakic. And there's a thing called target refraction. Just look at this one, keep it in your mind. So we will discuss, so what does it mean? And this gives the axial length. So this report, actually, this is the axial length value. So this is actually IULMAS 700 report. So just forget about the bottom part. We will talk about a bit later. Now IULMAS 500 only has the first two values. And what is this? There's a difference between the K1 and K2. This is the entry chamber depth value. This is axial length, entry chamber depth value, and the lens thickness, and white to white measurement. And whenever you look at the report, once you confirm your patient's details, you need to concentrate on, we have to always, we have to do the biometry on both eyes. Then only we can compare the report. Now, first we have to look at the axial length. So there's a tiny dot over here. So this will be commented at the end of the report. So this if it happens, actually this axial length is not correctly taken by the machine, so somebody has manually fed it. I mean, that means there's a problem for the picking the axial length if you have this sort of mark. So this side it was machine picked the axial length. And you have to see the difference in axial length in both eyes. Just remember, if it is a short eye or the long eye, or if there is a difference between both eyes more than 1 millimeter, you have to think again about the biometry. So short eyes, normally what we mean is actually below 22. The long eyes means actually it is more than 26. So in your practice, just keep a sort of rough guide where you need to repeat the biometry. So for me, actually, I take like a less than 22, or if it is more than 26, or else difference in both eyes, if it is more than 1 millimeter, so I will reconsider or repeat the biometry, and I will recheck the patient. So whether we will let it go, or we have to think again regarding the future proceedings. So that is number one. Look at both eyes. And then we have to look at the K readings, K1 and K2. Normally, general acceptable is actually K values 41 or less than 41 or more than 47, 46, 47. That's a range normally we take. If it is if it doesn't fit into that, if it is less than 41 or if it is more than 47, you have to think it again. And in addition, you have to see the difference between K readings. Now here it's about 0.85 difference, and this side the difference is 0.7. So if it is fixing into the normal range of keratometry, then naturally you have to look at the difference. So the cylindrical difference or the astigmatism. So if it is not fixing into the sort of normal range within sort of one diopter difference, so you should think again what it is. And another most valuable one is actually antechamber depth. If it is a shallow antechamber, always you have to remember the patient might be hyperopic, And whenever you go for the surgery, there's a high chance you are, because whenever we do phaco, actually we are playing in between endothelium and the posterior capsule. So there's a high chance we might touch the, we might go close to the endothelium. Therefore, we need to evaluate the specular microscopic value before we go in for the surgery. And now once we confirm those things, okay, this report can let it go, then actually what we are going to do is, we now say about, now we go for the formula a little later. Now this report, they have selected this axis of IQ, this SN60WF, that lens. If you think we are going to use this one, so say about, now if you are going to use this 26 diopter lens power, the target refraction you are going to get is minus 61. So now remember, now this is the target we are going to achieve, but there's a defaulted value from the machine. There's a target refraction, so there's a minus 0.5. So in this case, if you choose the IUL power 26, the ideal, the refractive outcome you are going to get is the summation between minus 0.61 and minus 0.5. It is nearly minus 1 diopter. And remember, this value is not the spherical value. This is a spherical equivalent value. So we will go it little later. Now, if you choose this lens 26, you will get a minus 1 diopter spherical equivalent value. Now, what does it mean? Now, remember, now we are going to use this 26 diopter lens. Now, imagine this, a purple color lens is a 26 diopter. So if you keep this 26 diopter lens into the eye, and if the surgery goes on perfectly well, sort of these purple color light rays will meet in front of the retina. So that's why it's called myopia. The image is forming in front of the retina. So that is nearly about minus 1. Actually not minus 1. If you think about that, this correction is minus 1. Minus 1 is spherical equivalent. And so then actually, if you want to correct this, the eye, if you want to get the correct emmetropia, we need to put the minus lens in front of the eye to diverge these rays onto the fovea. So that is the meaning of target refraction. So whenever you choose the IOL, you have to look at this one and this one. Then only you have to, depending on your personal experiences, you have to adjust whatever the lens power you are going to choose. And there are sort of recommendations to repeat the biometry. If it is an axial length, this is a value actually in the book, 21.2 and 26.6. But so your clinical practice, you can keep like whatever the easiest way, less than 22 or less, more than 26, whatever the way. The median corneal power 41 to 47, and if there's a difference between 2.5, you have to look at it again. Difference in axial length between fellow eyes 0.7 millimeter or more. Difference in mean corneal power more than 0.9 diopter. And now let's see few biometry reports what we have. Now these patients actually, now here see the whatever the formula they have used is SRKT formula. There's a target refraction is minus 1.5. And look at the report now. This is axial length 28.14. This side is 23.70. So there's a 5 millimeter difference in axial length. So it is a sort of red light here. And look at the K readings, 40, 53 and 56. Again, it is more than what we expect. It is over 47. But this side is within the normal range. So this eye doesn't look like a normal eye. So this report, you cannot let it go and fix for IOL surgery. And we need to repeat and discuss with the seniors or other colleagues before proceeding for the surgery. So there are three different things. Axial is difference, K reading is overvalued, and the difference in K readings is also huge difference. Minus 0.8 is about 3.14. There's a huge difference. And in this sort of situations, we cannot let it go. You need to get some advice before fixing for surgery. So what do we think of this patient? So this one actually, you need to think of why these K readings are higher valued, why the activity is higher valued, and why there's a difference. So it's this actually obvious condition is a keratoconus. You have to exclude the ectasia in these sort of patients. So we will see how we are going to proceed in these set cases in few minutes time. And coming back to IOL formulas, actually, there are a lot of formulas available. Now, when we go back to the history, there were actually the theoretical formulas, and then it changed into the regression formulas, and then it was sort of taken up by Vergence formulas, and nowadays it is basically AI-based, the formulas, and most of the biometric formulas actually, especially it's a Barrett Universal 2, is a hybrid. It's used the Vergence plus AI. And Hill RBF and Kane formulas actually basically the artificial intelligence based formulas. What we commonly use is SRKT, and we use the HOFAQ as well. So this is the newest tool, and the Hill RBF Kane formula also, it's available with us. And the advantage of having this Barrett Universal 2, Hill RBF, and Kane formula, these all the formulas, actually, we have the online access, and it's free of charge. We can easily check our IUL formula, IUL the power with this sort of the tools. So talking about SRKT, there is commonly what we use nowadays. So that use only the axial length and the K values. So it is generally recommended for normal eyes within 22 to 24. And the newer formulas, so they use actually additional readings. They use entry chamber depth, lens thickness, and white to white. So why? So they use these measurements to evaluate the correct effective lens position. So what does it mean by effective lens position? So this is the cornea, this is the lens, the crystalline lens. This is going to be removed and replaced by the IOL. So IOL is going to sit over here. So that is called effective lens position, or the ELP. So this effective lens position is being determined by the anterior chamber depth and the white to eye measurement. And some formulas actually they ask for preoperative refraction and all sort of other details to get more accurate effective lens position. So these newer formulas actually they ask actually Olsen, Huygens, and all sort of things actually they ask about these newer sort of measurements. Barrett Universal 2, we can use the newer for the sort of measurements, as well as even we can use axial length and the keratometry to get the Barrett Universal 2, the formula, into our hands. And now this is a little bit of a theoretical stuff, but this is the base for our practice. So just concentrate on it, I mean, sort of without paying much attention. So this is actually one of the paper which came out recently regarding, this is a prediction error with different measurements like axial length, keratometry, ACD, with the difference in axial length, how the IOL power is being changed. So this is a prediction error, and this is the axial length. So when we change the IOL, the axial length from 21 to 28, this range, so look at this red one, just forget everything, just just concentrate the red one. Red is a Barrett universality formula. In this one, so Barrett universal 2 is doing a reasonably good job during all axial length measurements within this range. And look at this. This is again regarding against the keratometry average. When you the keratometry 40 to changing from 40 to 48, the gain that Barrett universal 2 is doing reasonably okay with all the keratometry changes. And this is against different anterior chamber depths. Again, the Barrett universal 2 is doing a favorable job for us. And this is against the lens thickness. Again, the same thing. The Barrett universal 2 is with us for all the measurements. So it's as the name mentions, Barrett universal 2 formula is a universal formula for all of us to get it access. And actually, I would like to actually give you a sort of trial how to get the Barrett universal formula into your hands, because that will be very useful in your day-to-day practice. And before we go into the next one, now I will invite all of you to take your phones or whatever your device and put the sort of data, and please go to the Google. Okay, you get the Google and type there the APACRS, Asia Pacific Association of Cataract Refractive Surgery, APACRS. So once you put the APACRS, it will pop up Asia Pacific Association of Cataract. That's a www.apacrs.org site. Please click the site, APACRS website. Right? Hope everybody got it. And once you go to the APACRS site, just look at the top. Just below the big APACRS letter, there are small letter things, home, awards, blah, blah, blah. And there's a thing called IOL formula. It is just above the festival video something, IOL formula. Just click the IOL formula. Then it pop-ups the different formulas Barrett is going to use. So this is a TrueK, toric calculator, and there's a thing called Barrett Universal 2. So that is what we need for normal day-to-day practice, Barrett Universal 2. If you need the Barrett toric calculator, this is above one, that's a toric one. If you need the TrueK formula, especially it is very useful in people with the keratoconus or the radial keratotomy. So that's a different thing. Actually, we will talk in little later on sort of advanced formulas. Now we will concentrate on Barrett Universal 2. Just click Barrett Universal 2 formula. Now there's a pop-up, there's a disclaimer. So there's the small box called accept. The left-hand corner, you have to tick it. So I have read and accept. You have to put the tick on that, and then only you can accept it. You put the tick and accept that. Now you get the data sheet where you have to enter the values. Please put your name. Doctor's name it is mandatory. So you put your name, maybe few letters will be enough. You need to have patient's name also, something you have to put. Okay. Then actually you go to the, now I hope you got it. The doctor name, lens factor, and don't fill it. Put the patient's name and then put the patient's ID. ID doesn't need actually, if you put a name, that's enough. And there's a right-hand top corner, there's a thing called personal constant. So if you have the personal A constant value, you can put the value at the A constant cage. Or else, if you are going to use a sort of known lens, so you just touch the personal constant, you get different lenses. Like there's a top Alcon SN60WF, blah, blah. So you can go down. There are different lenses available. If you want to use the Alcon IQ, so just click that whatever the SM60WF, and then actually it will automatically fill for the whatever the lens requirements. So we don't have to put it anything. Now that part is over. Now, so we will put some imaginary values to these measurements. Suppose now there's a, okay, please select the OD or right eye. So axial length, we put like maybe like a 25.34. So K1, we put like a 42.34. K2, we put like a 44.56. And we have to put an optical ACD, we put like 2.56. And then actually you have to say what is your target refraction you are going to get. So normally what we can do is we can delete that 0 and we can put minus 0.5. So that's the target refraction. And below bottom are actually optional. Either we can put a lens thickness and a white to white. So that is available with IOL Master 700, but it's not available with IOL Master 500 or our ultrasound whatever measurements available. What we can use these triggers. Okay, we omit the bottom part for the moment, and we go for the top. And there's a thing below the patient data. There's a thing called calculate. So you just press the button calculate. Okay, again you get the same data form. Then look at the top. Again, look at the top. There's the next to the patient data, there's a thing called universal formula. Now you have to touch that universal formula. After the calculate button, you touch the universal form. Okay, you got it. Now you get the what is the value for your whatever the fitted data. This one say if you put a 16 diopter lens, you get a refraction of minus 0.45. And if you put a 17, you get a, so whatever you required IOL power, you can get with this sort of way. You just practice few days, or you can actually, you can teach this to your MOs. Actually, they will do the calculated IOL power for you. Especially this is very, very useful for long eyes or the myopic eyes. So remember to, it's a free of charge. You can just go to the website and get the value. And even the Hill RBF or the Kane formula, those also available in the net. Okay, now coming back to this, the formulas again. If you use now long eyes or the short eyes, long eyes is over 26. So there's a problem of actually calculating the axial length. Now, once you do the axial length, the measurement, it will be overestimated. If it is a long eye, axial length will be overestimated. So imagine the eye length is about 29 millimeter. So machine will say it's about 30. So that's the overestimation. Then what's happening? What we get is the post-operative hyperopic refractive surprise. So that is sorry, very common with the long eyes. So they get axial length will be overestimation. Because of the overestimation, we get a post-op hyperopic error. So therefore, until recently, so there was a recommendation by the Wang Kok modification. Those are actually two US eye surgeons, the Lee Wang and the Douglas Kok. So they made the modification. You can get it through the internet, the Wang Kok modification. For the different IUL formulas, maybe SRK-T is a different modification. If you go for the Hofer Q, this is a different modification. You have to get this modification. You have to add that to the axial length value, which is given by the optical biometry. if you get a optical biometry, if you get the 29 millimeter, whatever the axial length, you have to add that one with the Vankos modification. Then only you get the modified axial length. You cannot use the normal axial length, whatever you get from the IUL master, to get the reading from SRKT. You are going to have post-hyperopia. To overcome that, this Vankos modification has to be applied for axial length modification. But it's a great relief for us now. The modern formulas, especially the Barrett formula, we don't have to modify this axial length using this other modification. Whatever the IUL master value, we can directly feed into the Barrett formula, because he has done that job for us. Even the Hill, RBF, and the Kane formula, Olsen, Huygens, they don't need to modify the axial length modification, doesn't need in these formulas. But lot of people still use the SRK2 formula for most of the job cases. So if it is more than 26, if you use the normal axial length in the SRK2 formula, you have to be very careful. If you want to use this, you have to adjust the axial length with this Vankos modification. But the modern formulas, you don't need to modify the axial length. You can use the normal, whatever the given axial length to the IUL master or the optical biometry, we can use it for these formulas. This is for the long eyes. And the short eyes, again, is less than 22. So the SRKT, it's not recommended by a lot of people because of the high errors. So what I personally use is actually Hofer-Q formula, because that's available with our lot of machines. So we used to use Hofer-Q formula, which is less than 22. But now SRKT, as I showed you with the sort of difference prediction errors with the different axial lengths, this does a pretty good job, even the short eyes, maybe, but not less than 21. Up to 21, this may be better. But less than 21, you have to be very careful, because none of these ones are recommended for less than 21. So you have to look at few things, and with your past experience only, you can go with that one. So these two actually based on artificial intelligence, those you can use, and there's a the newer ones also. And this is very common scenario. Now, if something happens during the surgery, if you want to change the lens into the sulcus, what is the power you are going to use and how much you are going to reduce? So the recommendation is, now if you are going to put the sulcus implantation, so you have to calculate the IUL power thinking like it is in the bag. So we have to, because now this happens most of the time, whenever you change the lens, maybe lens type might be changing. So whatever the sulcus lens you are going to use, the same power, what you have to do, you have to calculate the IUL power. So thinking it is in the bag implant. And if it is you are thinking of bag implant, now suppose now if your bag implantation power is between 18 to 28, you have to reduce -1 to your sulcus lens. If it is more than 28, you have to reduce 1.5. If it is the 9.5 to 17, actually what you have to do, you can reduce 0.5. And if the short powers, no need to adjust. But remember this part, most of our cases, we will be able to use the IUL in the sulcus with the optic capture. If you are going to use the optic capture, effective lens position will be different. So in this sort of cases, you should not adjust your IUL power. You can use the same power, because it's like a positioning will be, it's like a same. And now we will just see actually few sort of examples what we are going to do. Now this case, now you check your data, and this is the axial length 25 and 24. There's a difference between more than 1, and there's a lens thickness. This is a K1 46 48 is about -150. This side K reading is -0.4. So there's a difference between K readings, but these are This is 48, 46, 48 is a higher side, and this is normal range, but then there's a huge difference between two sides K readings. So this one, we cannot let it go because there's a significant asymmetry between two eyes. So you have to look for the cornea, whether there's any sort of reasonable, you can reason out the difference, whether there's coronary scars, past surgeries, whatever, blah, blah. If there nothing, if there nothing happened, you have to always exclude the ectasia or the keratoconus. So to evaluate the keratoconus, what you do, I know a lot of people, they use the corneal topography for the evaluation of the keratoconus, but that is not recommended because the keratoconus is a disease which starts from the posterior surface of the cornea. You should have to have a system to evaluate the posterior cornea. So that is the tomography, not the topography. So the topography is nowadays actually is going away, and a lot of tomography technology is coming up. So we ordered actually pentacam. So if you look at the pentacam, you can see the values. So this is a bit of a complex sort of report. I mean, there are a lot of details available, but for our general practice, just look at this one. Actually, you can get little information and you can match to your practice. So you look at the K1, K2, this 46, 48. This is the steep the reading. Steep axis is being given by the red color. And the difference is being calculated for us is 1.6, and this is very handy actually. This one machine which gives the K1, K2, and it gives a pachymetry, is a the thickness value, and it gives the thinnest location the value, and it gives the what is the K max value. And if you look at the images, this is the front elevation map, and look at the back elevation. This sort of back elevation is huge. So so just look at this. There's a red dot, or the red dot is actually obvious. This is a keratoconus, and if the yellow one, there's like a foamy frustrate. And if you now, I will show you. This is the normally what you have to think about that. And if you look at the report, and this is the now imagine this one. This front report 45, 49 is difference 4.7, and the Kmax is 54, and the pachymetry values. This is the thinnest location 453. This is a front map, suspicious, and this is a elevation. There's a obvious elevation on the back map. So that is what you have to see. And look at the second report. This actually calculated everything for us, but there are a lot of details. For example, so you have sort of ABCD classification and also, but the clinical practice, you look at this data and look at this map. This says keratoconus. What's the level of keratoconus? This is a keratoconus level 2. So there is obviously he has done the job for us. So if it's keratoconus, that is keratoconus. Then actually you can work out on that part. So that is what's about the now what we wanted was actually we had wanted to evaluate the report, and then we got the pentacam report. It confirms this is a keratoconus. Now you cannot go with this normal SRKT formula, because if you go with the SRKT formula, so you are going to have hell a lot of problems in this keratoconus size. Here you need a specialized formula. So normally the indicated ones, actually you can use the Kane formula, or you can use the Barrett. There's a true K formula. So we will discuss those things in another day, how sort of advanced formula is going to work for you. So remember, if you miss this done, you are going to have a definitely huge refractive surprise. So end of the, you will not be happy, patient will not be happy. So remember, just don't let this report to go without looking at it again. And this is one of our cases actually. Now this one actually, this is the same patient actually. So what we did was actually, this is a keratoconus 2 to 3 level, and we use the true K formula using the keratoconus mode. It gives the 13 diopter power, and this is the refraction. It comes with the correction, and there's a target refraction -1. Actually, nearly we target about nearly -2.5, and did the surgery with the 13 diopter lens, and this is the refractive correction we got. So this is not pretty bad. So we can avoid, and even with the, do you remember now, even with the 13, if you target about minus, so this actually need a bit of experience with the your past surgeries. If you go for maybe 2.5 only, you will end up with -1 for this result. So it's just not a bad result at all. And this is what I talked to you regarding the biometric, the pentagram report. Nowadays, this pentagram is very vital tool. Actually, now even with the patient coming with the small cylinders, actually you will just give the glass. Instead of giving the glass, you can evaluate the sort of posterior of the cornea by doing the pentagram. So this is very useful. Then actually you can even look at the progression or whatever the differences. You have some objective measurements. And this is a newest of sort of this, in addition to my talk, actually, this is a newest tool. Actually, it's a Pentacam HD cornea. So this gives very sort of handy the results. So all the corneal details are very much valuable over here. And this is another report now, like this sort of differences. Now, this is one of our board patients. We can't just let it go. We have to work it out why there's a difference and this thing. Now, what we have been talking throughout was actually, now what we needed was actually, so how to get the proper biometry. So biometry machines, actually we have to get, now in summarizing, we have to go from ultrasound to the optical biometry. There's a huge advantage of going to the IUL Master 700. That's a source base, and it gives more valuable information for the biometry report. And in thinking of biometric formulas, so we know a lot of formulas, but remember, at least the universal 2, Barrett universal 2 is fits for most of our cases. So, and we have just went through how it is accessible through the online to all of us. And especially the long eyes, remember, if you use SRKT, don't use the axial length which is given by the optical biometry. You need to use the Bangkok modification. Otherwise, you can use modern formulas without modification. And the short eyes also, even though they recommend the Barrett Universal 2, or you cannot use SRKT, gives most of the values, or you can use Hofer-Q or the sort of other the other formulas. So actually, we need another sort of session with the sort of advanced formulas and how to choose IUL powers depending. And as I told you earlier, I told you actually we get the spherical equivalent value. With the report, what we get is, now imagine this patient, there's a -5 diopter cylinder. Now, if you go with the biometry report, now imagine that -5. So now let's see this one. Now this one, now let's imagine here is a value about -5. Okay, there's a K-rin difference is -5. If it is -5, and if you go for 25.5, so that's nearly 0. Okay, if you go for 0, that 0 means that the spherical equivalent is 0. Then if you put this 25.5 diopter lens, we are targeting nearly 0 spherical equivalent. Okay, if we are going to target this nearly the 0 spherical equivalent, so if it is a -5 diopter cylinder, if there's a cylinder, so spherical equivalent means half of the cylinder. So that should be 2.5 diopter cylinder minus, to compensate that, we have to have a plus 2.5. I will discuss this in detail in another session. So then if you put the IUL 25.5, the post of refraction will be +2, if there's a cylinder about -5, not this one. So the post of refraction will be plus 2.5 minus 2.5, whatever the axis, that is the refraction we are going to get. So that is why we have to be very careful. This is a spherical equivalent, not the spherical error, the spherical value. So in this sort of situation, so we have to go for like a half of the cylinder like well. So we will discuss those sort of advanced things a little later. So today I hope you all have got some idea about basic biometry interpretation, and whatever the questions you have, we can either today or later on we can discuss with those things. Thank you very much. Thank you, Mangale.
Thank you very much, Daya. It's very interesting. I think it's a very comprehensive account, which nicely covered all the areas. I think everybody learned a lot from it. I think we have very good, more than 60 participants, so that's a good achievement actually. We definitely need the second part of this. I would be grateful if you can do it on end of April. Is it possible
So,
there as
so
the second
okay.
part?
Now we let us go. Now I think we give little time, and I can just cover give the summary of this one. Plus, we can go for the little bit
Yes.
and the things.
Yeah, because it will be our next session will be at the end of April. We
No,
have a
I think
month's
no,
time.
the Mangala. So we will go with
Yeah.
somebody else's, and I will probably maybe we will give little time, and I will get it prepared, and I will let you
Okay.
know.
Yeah, yeah. Let me know this. Are there any questions? This is a very golden opportunity for you to discuss your queries and all. Anyone has any questions? Hello.
ඔක්කොටම හොඳට තේරෙනවා වගේ වැඩි.
No, very nice lecture. Yeah, very advanced and very nicely done. Thank you so much.
Okay, thank you very much, Ena.
Right. Okay.
Okay,
In
thank
the
you.
absence of any
Any
questions,
questions
we
that
can
you
wind up.
can you just
Yes. I can
yes.
collect the questions and let you know. So I'll make a
Okay,
little
sure,
Google
definitely.
form
It'd be great.
and put in
Okay.
the groups. Are there any questions? Hello? Okay, no, I guess. So I can put a small Google sheet and collect the questions and forward it to you there.
Okay, sure. Thank you. Thank you. Okay. Thank you
Okay.
very much. Okay.
So thank you
Thank
very
you
much
very
for the participation. And once again, thank you, Dr. Asa, for the excellent lecture. And so we'll wind up. Good night for you all.
Thank you, sir.
Okay, thank you. Thank you. Okay.